A beautiful Saturday morning, 11:04, and back with the Dr. Payne Show. Dr. Lewis here, taking your phone calls, 416-870-6400, star 640 on cell. Have issues? Would love to talk about them.
Welcome back.
Welcome back, buddy. Thanks, man.
Oh, I've been here.
Well, I haven't seen you, so it's welcome back to us here, happening.
We're sort of happy to have you back.
Yeah, it'll get better with time.
How was it? Good?
I was in Morocco for a week.
Very nice.
Different culture.
Yeah.
Wicked culture.
The world is a different place.
You got to see it. We were commenting before we went on air that my brother-in-law's family is Moroccan, sweetest family, sweetest people you'd ever meet in the world. And their houses, they're big on the inside, but on the outside they're very inconspicuous. And the kitchens are like literally it's 2 feet of counter space with a single little sink, a little stove, little gas stove.
And it works.
And a small fridge. And these people are producing food for 12, 13 people 3 times a day. And they demand you come and eat and enjoy and break bread and fresh lamb and vegetables. North America, $80,000 kitchens in people's houses and nobody cooks.
We have a different... It's funny, this being a healthcare-related show, but even when you look at the culture from a healthcare perspective around the world, my family is Italian descent. So, when I've gone back to Italy, there's... The average person in Italy, I find anyways, because I can't comment on every place, so much more educated on healthcare and proper management. When we've talked about here about when to use an urgent care center, when to go to your family doctor, when do you go to your physiotherapist, even over-the-counter medications. The average person just so well-versed, and I don't know if it's a cultural thing where it's passed down from parents to the children in terms of understanding these things, but we do. It's sort of analogous to what you're saying. North America just seems to be different. More entitlement that happens here, and where you think there should be someone doing something for you. But you're absolutely right. You got kitchens here that are 1,000 square feet and they're not being used, and then you go to a local restaurant and they got 300 square feet of kitchen and they're pumping out incredible meals. It's a totally different world. It's incredible, and I think it's very good to, as you were saying, to travel and get exposed to the reality out there. And in traveling, you also see what's great about our country too, right?
Absolutely.
We're not sitting here saying that.
No, I'm not
Canada,
moving tomorrow.
No. This is a great country, and there's a lot of great things that we have. But I think it's the point that we could always get better. And Greg was talking a lot on his show about the car industry, how we could, or the car industry can always improve. And healthcare is no different. Right? We can always be improving, and there's a lot of things that are done wrong, and some of it is grassroots where people just don't understand. Right. The other parts is systemic, where the policies that we have in place are probably not the best policies, and that's why we're here, why we do this platform, why we do this show, to shed light on those things, and how do we go about a change, whether it's in the shift of the way people think and understand things. And that's what we've been trying to do here. Something as simple as I think most of our listeners would now know. If I said, does degenerative disc disease matter on an x-ray? Most people would know that if they've listened to me. Well, no, it depends. Right. It's clinical. You got to correlate it, where, the common misconception is that, and I had a person yesterday. I was told I have arthritis in my back. I have degenerative disc disease. How old are you? 71. What kind of degenerative disc disease? Moderate. Yeah, well.
No, welcome to 71.
Welcome to the party. That is normal. And some people, yes, will have more than others. But what we're looking at is, does it correlate? Because we know very, very well that if you have arthritis on an image, that doesn't mean you have pain. And if we do random trials or random diagnostic testing on 100 people, 50% of those people will have some type of moderate osteoarthritis. Right. Not the same 50% have pain. So we need to correlate that stuff clinically.
It is 11:08 here. Dr. Payne Show, right into the calls is where we like to go. Tony, thanks for chiming in early. How are you?
Fine, thank you.
Good. What's going on with you?
I'd like to be Dr. Lou. About 2.5 months ago, I slipped and I twisted my knee. Mm-hmm. And I went to the hospital and they took the x-ray and they couldn't see nothing, so they asked me to have an MRI.
Right.
In the meantime, I've been going to the fracture clinic every month to see the doctor there.
Yep.
I went last week and I brought my MRI disc and they checked and he said I have a torn ligament on my knee and I might need a knee replacement. I said, I don't know about that.
A knee replacement in terms of replacing the bone or repairing the torn ligament?
I don't. He didn't explain that to me.
Yeah, well, that's what I would want to understand, right? So commonly if someone has a torn ligament, you would go in and repair the ligament. Now, it also depends on other things. If there's a significant amount of osteoarthritis in there, then maybe what they're thinking is, well, repairing the ligament isn't likely to provide much solution if this person has significant arthritis. And so maybe a knee replacement is the option. But, Tony, this is the example where I can talk to you on the show. We can have a dialogue, and I can talk about these things generally. But the only way for me to really know to comment should you be doing something or not be doing something is for me to assess you, to go through a complete history, physical exam, review everything, and try to piece together, well, what's the thinking pattern here? I would also encourage you that, you should be asking those doctors these questions. Well, why would you replace my knee if I have a torn ligament? Like, I'm not saying that it's wrong. I'm just saying I would want to understand why. Why is that being suggested?
That's why I couldn't, I didn't like the doctor there. He said, come back in 2 months.
Yeah, so, you don't have to wait 2 months to see me, so that's the good news. If you come see me, you will take a look at everything. Now, you said you do not have a fracture, but yet you were going back to the fracture clinic?
Yeah, the guy wants me to come back every month. I go there, he looks on my knee, says, okay, come back the next month.
Right.
And now he told me to come back in 2 months. Mm-hmm. And I heard you talk about this injection, take the blood. Would that help?
That depends, right? Like that's a common question. What you just said there, does something help? I don't know if it'll help you. Does it help in general with people who have osteoarthritis? Like I can give you an answer based on research. Yeah, absolutely. It can help decrease inflammation with people who have osteoarthritis, mild to moderate. But can I answer over the radio, can this help you with your problem? I don't know that. That is where I need to assess somebody in order to determine, go through the extent of what an examination process is, to understand the risks, the benefits, if it's likely to work. So could it work for osteoarthritis? Yes. Could it work for your osteoarthritis or your torn ligaments? I have no idea. I would have to assess you.
Oh, I see. Okay.
Okay.
Thanks, Tony. Appreciate that. 1-855-55 Dr. Lou, DRLOU, info@pancarecanada.com. Back to your phone calls. I see you there, Vincent. Hang on. And for you as well, plenty of time. Just getting warmed up here. 416-870-6400, star 640 on your cell. Dr. Payne Show, Global News Radio, 640 Toronto. And we have relabeled things to the Greg Carrasco Show. Greg will be talking about knees. And
Jeez, look at this. That mistake never happens on the Greg Carrasco Show, eh? This is
the
never
Dr. Payne Show.
Yeah, this is never the Dr. Payne Show. It's okay. I wonder if Greg listens to the show. I listen to his show. If he's listening, he should call right now. That would prove if he's listening.
I think he snuck over when Jody was in the... Oh, there we go.
There we go. Much better.
This is the Employment Hour with
Yeah, exactly. Everyone benefits from this
the
hour.
John Oakley Show. Vincent, how are you, pal?
I'm doing great. I love you guys' show.
Thank you.
Thanks, man.
Thank you.
What's going on?
Just a quick thing. First of all, I'm extremely flat-footed.
Okay.
And over the last probably, I'd say, year, I've gotten just my feet feel like they're asleep all the time. They're tingling all the time.
Okay.
So I've been tested for diabetes, and that's a negative.
Good.
My family doctor was insisting that maybe it was nerve damage caused from smoking. So he sent me to get my nerves checked, like I went to a specialist.
Yeah,
all that came back fine.
Good.
So then he sent me for a blood flow test where they hooked me up to a whole bunch of things to check all my blood flow.
Right.
All that seemed fine.
Good.
And nobody can seem to figure it out. And it's just like it doesn't really hurt that much, but every once in a while I will get a really fast, sharp pain in a certain area of one of my feet, but then it goes away. But it's nonstop tingling constantly. I mean, from the only time I don't feel the tingling is when I'm sleeping. But other than that, it's just baffling to everybody. And I'm just wondering if there's anything I can do about it. I mean, I'm used to it now, but it still drives me a little crazy.
Yeah. So I think the process is definitely underway. So, I mean, you've ruled out that it's not a neuropathy due to something like diabetes, like blood sugar. You've ruled out that it's not nerve damage per se, like in terms of an entrapment. Now, the one thing that I will say about the nerve conduction test and those things, number one, they're not diagnostic for any spine-related nerve problems, so they're good for the extremity, but they also don't take into consideration positioning all the time. And that sometimes is important with what might be setting you off. So that's that. So there's essentially where I'm going with this is there's other potential causes as to why you might have that, right? You've ruled out some type of issue related to vascular, some type of issue related to peripheral nervous system, and some type of issue related to blood sugar. But there's many other things that can cause that type of presentation. Just as an example, liver issues, for example, can create that type of problem. Lung problems, if you're a smoker, making sure that there's nothing else going in the lungs can create that type of problem. Even things like, and I'm not suggesting this for you, I'm just talking out loud or thinking out loud, is things like STDs, right? So HIV, AIDS, different types of syphilis can create that type of presentation. Now, I'm not suggesting that that's what you have. I'm just saying that you've done part of the diagnostic process in terms of trying to figure it out, but haven't gone the complete way. One of the most likely things that it probably is just mechanical issue related to function, movement of the body, and something like that, where there's a breakdown over time. I'm
sorry. I've been told by other people and stuff, like the specialists I went to see, maybe it's just due to my extreme flat foot, and I'm 51 years old, and maybe it's happened because of that. But also, this might be a factor too. I've been a truck driver for 33 years.
Right. So there you go.
So all the time, and I just don't know if it's something that could possibly be dealt with, or if it's just something that I'm going to have to live with, or should I keep pursuing something?
Based on what you've said to me thus far, I would say the next logical place to look is your low back. Right. So if you're sitting a lot, do you have some type of bony change or disc herniation putting pressure on that nerve with certain positions? But come see me. This is the perfect example where, and this is not for you to know, right? But this is for the healthcare professionals. You've only gone part of the way in the diagnostic process, right? To just say, oh, well, it's nothing else. Well, no, it is something. Something is causing it. So you don't just stop once, 3 out of 10 things have been ruled out. You have to, well, what about the other 7 things that can cause it? And so I would say, based on what you've told me so far with your history of truck driving, and with what you're describing, the next logical place for me is checking out the low back and see if there's some type of pressure that's happening there on the nerve that's creating that symptom for you.
Okay, so the best thing to do would be to make an appointment with you.
That's right, sir.
Discuss with you what I've already told you, what I've already.
Yeah, well, we would go
further.
Yeah, we would go in depth and we would do a physical exam. Something new that for all my listeners, I've also got a sports medicine doctor that works alongside me now. So anytime any more specialized imaging or more specialized knowledge, we can have access to that right away. So so give me a call, and it's that easy.
Perfect. Then I'll be seeing you soon.
Okay. Thanks.
Vincent, thank you, sir. And for you as well, 1-855-55-Dr. Lou, DRLOU, info@paincarecanada.com. And we have plenty of time for you to call in just like that. Get your stuff out here. Get some answers. From the get-go, 416-870-6400, star 640 on cell. Dr. Pain Show, Global News Radio, 640 Toronto. You have questions about your health, pain concerns. That's what we talk about every weekend here on the show. 416-870-6400, star 640 on cell. Dr. Lou here to answer your questions, get you on the right track to doing something positive. Rosemary, good morning. How are you?
Fine, thank you.
Good. What's your concern?
Okay, I've got a problem with my lower back. It's my very, very down near the bottom. And the thing is that somebody thought it was just a pinched nerve or something. But when I walk, I have no pain. No, when I sit down, I have no pain.
Right.
But when I walk, I can hardly walk.
Okay, because you get pain into your legs?
It does go down to my legs sometimes, yes.
Yeah. And how old are you, Rosemary?
76.
76. And have you had your spine x-rayed or any other type of imaging?
I had a CAT scan.
And what did it show?
A while ago. I don't know what it showed. I'd never heard anything back from it.
Okay, well, I would follow up. So one of the things when someone starts to describe pain with walking but sitting is fine, and it goes into the legs. So, okay, before I jump to that, let me ask you another question. If you are walking, does walking cause numbness, tingling, pins and needles, any type of weird neurological sensation into your legs?
No, just it's like my legs are aching. I can't.
Okay, aching, right. And then, but if you sit down, it gets better immediately, or it takes some time?
No, immediately.
Yeah, so that's usually something that's consistent with spinal stenosis. where the bones. So spinal stenosis is essentially where there's a narrowing of the holes where the nerves come out of the spine. Most often it's due to just simple degeneration. Well, I shouldn't use the term simple, but just degeneration of the spine. And once those holes become small enough, it starts to put pressure on the nerve based on position, and based on the anatomy of humans, there's more pressure on those nerves when we're standing or walking versus when we're sitting. So your symptoms seem to be consistent with spinal stenosis. Now, again, I would have to test that in order to be certain. I'd have to review the CT, maybe even take a new X-ray. Just to get some type of baseline or simple imaging to assess it quickly. But those symptoms do sound consistent with spinal stenosis, which is that narrowing of the holes where the nerves pass through. And so, if that's the case, now that I'm not going to lie, it's not an easy thing, but it's not impossible to treat. And there are ways to get better. It's not an easy road. And it's also not a full road to recovery, because when that happens, that is what it is. It's sort of like, think about diabetes. You wouldn't just take metformin 1 or 2 times or some other type of pill and be cured. You would have to manage it. And so that's what spinal stenosis might be. But step 1 is, again, making sure that it is spinal stenosis. But just based on those quick questions, which seem to be hallmark features of spinal stenosis, it seems like that's what the issue could be.
Okay. The thing is, I had open heart surgery last December, and I was fine before that. Mm-hmm. And just after this year has been just terrible. Everything's been wrong with me.
Okay.
So I just, you know what I mean? I just get that I'm to the point where I'm very tired. I'm tired. I can't walk. I can't do anything.
Okay. Yeah. I mean, I don't. Is there a question with that comment, or that's just a comment you wanted to make?
That's just a comment.
Yeah, okay.
Sorry.
Yeah, no, fair enough. I just wasn't sure if there was something between that. I mean, the reality is, the unfortunate reality is you get older and these problems will start to happen. And it could seem like, don't think that the heart surgery would have caused spinal stenosis. That just may be correlation, right? And so that's a big thing. Just because two things may coincide in time doesn't necessarily mean that there's a causation effect where one equals the other, right? So, but in having heart surgery suggests you have a heart problem. Your cardiovascular system does matter towards how your body feels and the ability for muscles to use oxygen, do what they have to do. So that is an important thing to consider. Maybe there's a component where this is coming from that. I don't know. That's where I would need to assess you in order to determine that. Like, when I'm just using your example to speak about spinal stenosis, because that's what you can also get what's called vascular claudication, which is similar to neurogenic claudication, which is consistent with stenosis, spinal stenosis. The difference is you said that your legs feel better immediately. So nerves will tend to feel better immediately if you take the pressure off of them, versus blood flow issues would take a little bit more time.
Okay.
Okay.
Okay, so is there any way that I can make an appointment to come down and see you then?
You absolutely. Yeah, go for it, John.
Rosemary, appreciate the call. It's 1-855-55-Dr. Lou. That's DRLOU. Again, 1-855-55-Dr. Lou, or info@paincarecanada.com. Jack will get to you and your calls as well. 416-870-6400, star 640 on cell. It's a Dr. Payne Show. It's right here. Global News Radio, 640 Toronto. It is 11:31, halfway to go, so you still got plenty of time to call in, ask your questions. Bring them on, 416-870-6400, star 640 on cell. And we'll mosey on. Jack, good morning.
Hi, good morning, gentlemen. My question for you, Dr. Lou, is I've been having plantar fasciitis for years now, for months at a time sometimes. Actually, I just got over an episode not too long ago. It's extremely, extremely painful for me, especially in the morning. I had orthotics done for me. What's kind of baffling for me is it just comes and goes for no reason that I'm aware of, at least. And I just wanted to know what sort of remedies or what sort of steps I could take to try to mitigate it when it does come on. I've tried, rolling the cold pop can or the baseball or whatever it is to try, but that's usually temporary. Mm-hmm. The only good thing about it is I kind of learned to correct it by walking on the ball of my foot, not to aggravate the pain in my heel because it literally feels like a nail is going into my heel.
Right. And so besides orthotics, have you done any other formal treatment?
No, I went to see a chiropodist.
Yep.
I was given orthotic, which does help because throughout the day.
So I think from the get-go the thought process is wrong. So orthotics should be like, what's a good example here? If you have a foot that has a problem and you put an orthotic in, the orthotic should be designed to hold the effect of some desired treatment once you've removed the aggravation. So that would be step one for me. So the home remedies, like the reality why you continue to have this issue is one of two things. Either the home remedies, like I'm not a big believer in home remedies unless it's like something small or for a management issue. But to try to solve or have a good handle on a problem, you need to deal with the right professional, is my opinion. And so if you've been having this consistently now for years and it's that bad, it's likely related to a functional issue, something that you're doing that you may be able to change that could provide some benefit. The second thing is you need to get it treated properly, like true physical treatment, because to just slap an orthotic in there is not going to solve the problem. And I mean, that's not your fault. It's a money-making machine, so it's easy to just give somebody that because there's a big price tag on it and there's very little work involved. And I mean, I do orthotics for patients too. I'm not going to sit here and say that I don't do them, but it's not just a standalone solution. So if you have this chronic issue, if you really want to manage it properly, I would say stay away from the home remedies right now and try to get this diagnosed properly in terms of what exactly is potentially causing this and what are the right things that you should be doing from a formal therapy perspective to, like you said, mitigate what the impact it has on your life day to day and prevent exacerbations to be as bad or as intense as they are.
Well, to the best of your knowledge, what usually causes it? Because I don't have any extenuating physical sports or anything like that.
No, it
literally comes and goes.
It's a cumulative plantar fasciitis. Like we are on our feet all the time. Like, to ask me what causes it is like what causes low back pain. It's so hard to say. Like, we are really not, my best answer for any of those things is we are often not designed for the world that we live in terms of from an evolutionary perspective. And the other thing is that a lot of people do things that their specific bodies are absolutely not designed for. So like the example is I meet some people who are runners and it's like I look at them functioning. It's like you should not be a runner. Like there's nothing good in your functional track that would make running a good idea for you. And that's the reason why some people become Olympians in certain things. Like Michael Phelps is a world-renowned swimmer and the best ever for a reason because his body's built for that, and you and I can try, and we're never going to do that because our bodies just aren't built for that. And so it could be the shoes that you've been wearing, the pattern of the way you do things, the way you sit, the tightness on. There's a million different things it could be, but that's where functionally assessing someone could at the very least help to figure out, well, what is it and what can you do to potentially change that.
And is it normal to last sometimes for weeks? And
it's normal for people.
I had it from February until June.
Yeah, so that just means it's just not being treated properly, right? That's what that means. And you are the classic example of when people think that this stuff can just kind of go away, that it continues to come back. Every time it comes back, it might last longer, it might be more intense. That's the chronicity, right? Like that's where issues, when dealt with early, like I had a conversation with a lady the other day who came in with a very, very bad scoliosis. And now she's got all kinds of low back pain and all this stuff, and it was never caught when she was young. Like, you know where these functional things should be most, like there should be formal programs in place where we look for these things when our children are young, because that's when we can intervene to truly protect and change. And looking for some key things would be very, very important. So, you know, there's a lot of reasons why this could be happening to you, and there's also a very clear reason why it keeps happening is because it's never being treated properly. It's not being dealt with the way it should be. All you're doing is sometimes putting temporary Band-Aids on it, and sometimes that Band-Aid might be good for a month, sometimes 6 months, but you know, there's never a true solution being implemented.
Well, what do you know about sound wave therapy? I was reading up on that.
Shockwave or sound wave?
Is it I believe it's, if I'm not mistaken, something to the effect of sound wave therapy. Where, do you know anything about that, and if that would at all be applicable?
I've never heard of sound wave. I think you mean shock wave.
Okay. So how would that play in if that?
Yeah, it's definitely the research for it around plantar fasciitis is very, very good. One of my colleagues, who's a medical director for or a medical consultant for Shockwave Canada, and he's an orthopedic surgeon. We've had him on the show before, so I know a lot about it, and we do it at our clinics for this type of issue if need be. Right, like the difficult thing here is when people want to start backwards, where they want to jump right to, here's the treatment I want to do. Let's make sure I fit into that. That's the wrong way to work at this. You got to start from scratch. Like, let's look at it. Let's pretend we don't even know it's plantar fasciitis. Let's just state the facts. The facts are you have ongoing foot pain that consistently keeps coming back. Let's figure out what's causing it. Even if it is, we deduce it to be plantar fasciitis. We got to start from scratch, and we got to move that way, not backwards.
Right. Okay. All right. Well, thank you so much.
No problem.
For that wealth of information.
Okay. No problem.
Jack, appreciate that. Moving forward, 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. We'll take a short break. More of your phone calls. Bring them on. John, I see you there. You're up next, and you have time as well. 416-870-6400, star 640 on your cell. It's a Dr. Payne Show. Global News Radio 640 Toronto. It is 11:41. You have time if you're interested, want some answers, at least get it started. 416-870-6400, star 640 on your cell at 11:41 Saturday. What else is going on in your world, pal?
Lots of stuff going on, yeah. I mean, so there were a couple of interesting cases that I saw this week as well that I wanted to share. So I had we sort of talked this about off air, right? So I had a person with chronic low back pain came to see me, and they essentially said, like, to summarize it, that if they couldn't get out of this pain, life was not worth living anymore. That's how serious this was for them. And I basically said, okay, well, let's go through what you've already done, because this is obviously, you've done stuff. You don't get to that point and
day one.
Yeah, exactly. Yeah. Had been through lots of stuff, all kinds of injections, medications, you name it. She's done it. And it was like, okay, well, have you ever done any good rehabilitation? No, right? Like, consistent answer. And so I basically sat there. I said, listen, I'm going to give you an answer. You're telling me that life is otherwise not worth living if you can't control this. You have two options left, because you've done everything else, but you've never done good rehabilitation. And she mentioned that one time she had tried, but after she did the exercises, she was in a lot of pain.
Makes sense.
And it's like, well, that's exactly what's going to happen. And number two was the psychological component. And I was telling you about one portion where one of the things that I'll do, and I almost don't like giving it away, because then when I examine people, but I said to this lady, I said, can you come into the exam room? I said, bend down, touch your toes. She said, I can't do that. I can't bend and touch my toes. I said, okay, sit up on the table for me. She sat up on the table. She was sitting, and sitting is already a flex posture, but your legs are dangling. I took one leg and I lifted it up. I said, does that hurt?
Like in a pike position type of thing?
Yeah. I said, does that hurt? She says, no. I said, okay. I grabbed the other leg. I lifted both up together. I said, does that hurt? She said, no. I said, okay, I'm going to support your back and sort of lift them a little bit more. I said, does any of that hurt? She said, no, it's fine. I said, well, can you tell me what the difference is between bending when you're standing and what I just did to you?
Just the
and she was just blown away. And I said, and the only reason why I'm showing you that is not to I caught you. It's not I
ridicule you. Yeah.
It's about what's called fear avoidance behaviors. So people who have chronic issues develop what's called fear avoidance. So they fear doing things because they think it will hurt them. And it's not even based on fact. It's not like, well, it does hurt. It's just the belief that it will hurt prevents you from doing it. Exactly. Yeah. And you have to, a big component, and that highlights that psychosocial component of pain. You have to overcome that fear avoidance, that fear of these things. And I educated her on hurt versus harm. And we've gone through this. Not everything that hurts you is harmful, like exercises. In this case, of course, you're going to be in pain after you've done something to build up your core. That's what exercising is. But that's not harmful for your low back. Versus sitting down and doing nothing doesn't hurt at all, but is incredibly harmful long term. Right? So that those two things are not always equivocal. It's not hurt equals harm. Sometimes it doesn't. And what you're looking for is avoid the harmful, and it's okay to do the hurtful things, especially if the hurtful things are likely to lead to improvement. And that's what exercise is. And if you don't overcome that stage of going through that process, then good luck. Like you're never going to get to where you need to be. And the research is consistent when it comes to chronic low back pain. The best research we have, you got to rehabilitate your core. And this is not talking about doing crunches. This is working on small intrinsic muscles that control the stability of your spine, and then moving from those small ones to bigger prime movers. And this is a process, and it's graded, and it's not. I wouldn't give you the same rehabilitation exercises that I'd give a 70-year-old woman. Mm-hmm. We would start it differently, and the advancement would be based on who that person is as a person, what their functional limitations are. You don't just it's not like a cookie cutter approach. Here's a piece of paper and it has every exercise, whether you're 15 or you're 55.
115, go exactly. Do it.
Yeah, that's not the way. Graded exercise, there's an art form to it that you have to work with somebody to do it. And one of the things that I hear consistently is, well, like it's going to be expensive to see somebody. It's like, no. You're going to be seeing somebody in my team once every 2 weeks to hear the exercises. Let's make sure you're doing them right. Let's spend an hour together right now. Okay, go have fun. Go do this for 2 hours.
Diligently.
Or go do this for 2 weeks, diligently, religiously, all the time. Come back. Let's see where you're at, what's happening. Let's make it harder. Let's challenge your body a little bit more, because that's what happens, adaptation. You can be perfect at that baseline exercise that we need you to do, but if you don't intervene to prevent adaptation in the body, then you're just going to be in the same place. And then I had a person one time ask me, well, after I've done this program, can I then stop? No, you can't stop. This is what you need to do for the rest of your life if you want to be out of chronic spine-related pain. That is the best answer to it. Can you have slip-ups along the way? Yeah, absolutely. But if you want a true solution to chronic low back pain, if you've had chronic low back pain and you think you've tried everything, I can almost guarantee you that I've met very, very few people that have tried the appropriate rehabilitation, because if they have, they often are not calling me. If they've done it right, they've got it under control, they are managing it, they usually don't need to call me. But if you're listening now, you've got chronic low back pain, you think you've tried everything, you even think you've tried the exercise component, if you're still in pain, it means you haven't done it right. Give me a call, because there is a way for you to find a way out of that. And again, I'm not advertising a miracle here. I'm not saying you're going to do this in 2 weeks, you're going to be 100%. I'm even not saying that if you do it for 2 years, you're going to be 100%. Most people living with chronic pain aren't looking for 100% improvement. They're looking for 30, 40, 50, just so they can live. And that lady that I saw yesterday, her pain, she said, is an 11 out of 10, is what she said to me. And she said, if I could even be at 5 or 6, it would be like
new life,
like a miracle. And it's like, yeah, but that's realistic. And realistic goals are very, very important. There's no miracles here. There's nothing, and none of it's easy. There's no quick fix. Like, there's no gimmicks here. It's hard, consistent work. If you do the hard, consistent work around rehabilitation of the low back, you can improve your chronic issues.
I find it amazing how many people, when it comes to rehab and doing exercises, they think it has a termination date.
Yeah, well, it's the same thing with people with losing weight, right? Where we've done a better job when it comes to like the word diet and shifting the focus towards lifestyle change, so that suggests
a change of diet,
ongoing,
not on a diet.
An ongoing process that is forever. And if you deviate from that, then we just need to find a better way. Rehabilitation is an ongoing process that you have to continue to do. It's the same as the cognitive behavior therapy. That's not something that stops. Yeah. You do it still. Now, you may not do these things in the same way all the time, right? Like even the rehabilitation, it doesn't mean that you're now still spending an hour every day doing rehab like you were at the beginning of when you were doing this. Maybe now you can get through what you need to do in 10 minutes because of how, the good shape that you're in, all of those things. But it's by no means easy. There's no termination. This is consistent hard work. And if you do it, you have a good chance of at the very least, improving yourself to the point of getting, and it's sad because I hear all kinds, and I hear programs even on this station about, the opiate crisis and people in chronic issues. Like the best research, no other, like there's the medications, the surgeries, the physical therapies like physio, massage, chiropractic, all of it plays in a very, very important role, 100%. But the one thing that's consistent, that if you truly want to get better and you have chronic low back pain, is rehabilitation. Even neck pain is rehabilitation. In fact, I would argue with anything where you have a chronic issue, you need to be strengthening that area and rehabilitating it perfectly for you to have your best chance. And that's where the conversation should be at. We shouldn't be talking about anything else, because if you can do those things, then that's your best chance.
Short break, back at it. You have any questions or comments in that regard? 416-870-6400 star 640 on cell. Right till noon, Dr. Payne Show. Global News Radio 640 Toronto. It is 11:52. Last few minutes to go here. Dr. Payne Show, by the way, when the show is not on, 1-855-55 Dr. Lou, DRLOU. Write it down and info at paincarecanada.com. Paul, thanks for calling in, fella. How are you?
Good, thanks.
What's your concern?
Yeah, I've got pains that seems to move around.
Okay.
My right knee mostly, and then sometimes in my ankles, and right now in my wrist. Sometimes my right wrist, and then my left wrist.
Mm-hmm.
And, it seems to change, from one part of the body to the other.
Okay.
And I was just wondering, what could I do about that?
Have you had it checked out yet by anybody?
No, just by family doctor.
Okay. What has your family doctor said?
About him, and he didn't really say anything much.
Right. So then you have not had it checked out. That's where you need to start. You need to get this investigated to try to figure out what's going on. I can help you with that. You can come see me for an assessment. But that's where you can also see your family doctor again. You could see somebody else. I'm not trying to sell you on just me here. But that's where the process needs to start. If you have these issues, that's what you need to do. You need to figure out, well, what potentially is it? Is it just the breakdown of the body? How old are you, Paul?
68.
68. So, I mean, you're not in your 90s. So there's got to be, so it's a matter of figuring out, is it related to breakdown of the body? Is it something that's potentially systemic? Or is it just osteoarthritis? There's a lot of different things, but you need to get it checked out. And that's where you got to start. Otherwise, there's no other place, right? If you don't get it checked out, then it's very hard for anyone to make a recommendation on what you could be doing.
Okay, because one other thing I'd ask is that is your services covered by OHIP?
Some treatment services are covered by OHIP. Some are not, depending. If you need physiotherapy, then that's covered through extended health plan. So it very much depends on what the service is.
Well, I've got extended health coverage.
Yep.
Oh, good.
Okay.
But,
so again, it very much depends. If I refer someone to a surgeon, that's covered by OHIP. So again, it very much depends. But I don't know. Sometimes you don't have to have any coverage or any significant expense because it's just a matter of doing some stuff at home. There might be things you could be doing on your own. So again, I don't jump to the conclusion on what the treatment is. I just start with where I know is the right place to start, and that's the diagnostic process.
Okay, it's because I just wondered because if I come to see you, whether or not I had to pay, a bunch of money up front or not.
No, my assessment when people see me is $75, but I spend a long time with each patient, but that's it. That's the only fee.
So if I come to see you, I got to pay $75.
Correct, yeah.
And that's not covered by OHIP?
No.
Or extended health care?
You could submit it through your extended plan. It might be covered, yes.
Okay, and how could I get an appointment to see you?
Call 1-855-55 Dr. Lou, or you can email me at info@paincarecanada.com.
And how long would it take to get an appointment?
So one of the things of what I do is I only do assessments. I do no treatment, which means I can get in people pretty quickly, usually within a week or 2 weeks. That's the whole reason why I do this.
Paul, appreciate that call again. 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. There you go.
It's simple.
Simple, man.
Simple.
Couldn't
Come
be simpler.
see me, and again, I mean, I think one of the biggest things, I had somebody call me yesterday as well, and I was talking to them, and they wanted to come see me, and they said, one of the reasons why I really want to come see you is it sounds like you explain a lot, and I just really need an understanding. And I said probably the most important thing of what I do with my patient interactions is that I explain everything from what I'm thinking, like as we're going through it, all the way to what I'm doing, what I'm testing, all the way to what I think it is, what I think the plan of management should be. I really, really, really want people to understand. And again, I always go back to scientific evidence. One thing that is consistent in the efficacy of any treatment is when the person understands and is educated. And that is a big deal. And so I make sure to do that part. My team makes sure to do that part because it's imperative. It's so important that someone understands. Like, you know, it's the same thing. You wouldn't just go invest your money with someone and not ask anything and not understand.
You want to know.
You want to know, right? You want to know. And it's very important. And even if you're one of those people that says, well, I don't want to know for my health, it's wrong. You have to know. And if you don't want to know or you don't think you can understand, make sure that someone is there with you that can understand and does want to know.
Till next time, you know the number. It's 1-855-55 Lou, DRLOU. Email simple as well. info@paincarecanada.com. Use that number, get hooked up, make that appointment, and get on the road to where you should be. In a good physical place, at least, if not a mental one. Dr. Payne Show back next weekend right here. Global News Radio, 640 Toronto.